Okay. So yesterday we stopped with septic arthritis. I went over that and I was explaining to you guys that a lot of times people will get this from things like gonorrhea or some other bacteria. It usually is going to happen in one joint, a lot of times like in a finger. It can also happen though from introduction of that bacteria from like trauma, some sort of non-sterile injection. So, somebody shooting up drugs or surgery. Secondary infection because of bacteremia. So, again, this is going to be infection or septic arthritis in a single joint where that joint's going to be red, swollen, and painful. I would know that one. A lot of times, a history of trauma, surgery, or spread from some nearby infection like osteomyelitis. Again, bloodborne bacteria like gonococcus or staph. Sometimes Lyme's disease can also cause this. All right, now we're talking about psoriatic arthritis. This is an autoimmune form of arthritis, and it's accompanied by psoriasis. There's 5 forms of it: symmetric, asymmetric, distal, interphalangeus. You should just basically know what it is. Okay. That's what they're going to ask you about. They're going to expect you to know it's autoimmune. They would expect you to know the signs and symptoms. So, signs and symptoms of psoriatic arthritis are going to be swollen, tender joints in one or both sides of the body, morning stiffness, swollen fingers and toes, painful muscles and tendons, scaly, skin patches that can get worse, and a flaky scalp. Also, fatigue and nail pitting. So, a lot of times, what we'll see is separation of the nail from the nail bed. That's also known as avulsion. We talked about avulsion earlier. Eye redness, eye pain. That eye pain comes from uveitis. That's the uvea, which is kind of in the center of the eye. So that part of the eye is inflamed. Next is gout. I guarantee you they'll probably ask you about this at some point, either on the quiz or in the test. It's also known as gouty arthritis. Gouty arthritis is the same thing. Here we have uric acid and crystals, and they're being deposited in the joint. We'll see this a lot in your diabetics. This can also happen from someone who's had like radiation, where the cells or certain chemo where the cells have been lysed and broken down. And as those cells are being broken down, they're releasing uric acid in the body. So it causes an acute inflammatory response. Usually we'll see this in the great toe of someone. Uric acid is considered a waste product of purine, which is usually excreted from the kidneys. These clients can develop hyperuricemia, meaning they have an increase in uric acid in the body overall. And of course, it's an acid, so that can cause a problem right there. So gout usually affects one joint, one single joint, like that big toe. Acute inflammation comes from the deposit of that uric acid into the cartilage. They'll also develop something called a tophus or tophi. This is a large, hard nodule, and it's made out of uric acid or uric crystals. And it can get into that joint. It's going to cause inflammation, redness, swelling. And usually they'll have the attack of the gout first. The tophi will develop a little bit later. All right, so we have uric acid building up in the blood. The symptoms cause the pain. Again, that tophi, that uric acid building up in the blood, the crystals. So first the uric acid and the crystals will be deposited there. That'll cause inflammation and redness. And then after that first attack, that tophi can develop. So issues with gout, too much uric acid in the body made from the breakdown of the purines. Some of those purines come from foods that we eat, like beers, certain meats, seafood. So these are all things that they advise diabetics that have this. Usually you're going to see this in diabetics whose blood sugar is out of control. And the purines break down, they become what we call urate. Normally that goes out of the body in urine, but here the body is not excreting it because these crystals are forming. Chemotherapy, metabolic abnormalities, or genetic issues can lead to this. So we'll have inflammation, redness, swelling in the joint. They can also develop uric acid kidney stones, okay, especially if they develop that hyperuricemia where they have too much uric acid in the body. Next is ankylosing spondylitis. This is a chronic progressive inflammatory condition. It affects your sacroiliac joints, the intervertebral spaces, your costovertebral joints of the skeleton. For women, they tend to have peripheral joint involvement more than men. It usually happens after about 20 to 30 years old, and it's considered autoimmune. They don't know the reason, and also genetic. So, autoimmune with a genetic base. So, the vertebral joints will become fixed and inflamed. They'll have fibrous calcification and fusion of the joints. It's called ankylosis when the joints fuse or become fixated. And because the joints are fixated, remember they're supposed to be movable, okay, it causes them to lose mobility. Inflammation can start in the lower back of those sacroiliac joints and progress up the spine, and eventually they'll end up with something called a poker back. They can also develop kyphosis. Remember, kyphosis happens up around the thoracic area on the back. It causes that rounding of the spine, and that's going to put pressure on the lungs and affect their ability to breathe. Osteoporosis, also common, and that can lead to compression fractures. Remember, we talked about with osteoporosis, they lose bone density and mass, and because of that, they can develop these compression fractures in the vertebrae. Lung expansion limited because of calcification of the costovertebral joints and the reduction in that rib movement. So another thing that is also affecting the breathing here. Signs and symptoms are going to be low back pain, morning stiffness. Pain is worse when lying down. It can radiate into the legs. It can feel something like sciatica pain. Usually the pain is relieved when they get up and they start to move around, walk a little bit, do mild exercise. As the calcification develops, the spine becomes more rigid. Flexion, extension, and rotation would be impaired here. For some people, they'll develop systemic signs like fever, fatigue, weight loss. They can also develop uveitis or iritis in the eye. The posture that's characteristic for this ankylosing spondylitis is here. Okay, so you can see the hump developing on the back there. The hallmark of spondylitis is involvement of the sacroiliac joints while the disease moves throughout the body. The sacroiliac joints are located at the base of the spine where the spine joins the pelvis. It can cause inflammation, pain, and stiffness in other parts of the body, like the shoulders, the hips, the ribs, the heels, sometimes the small joints in the hands and the feet, and eye involvement. So again, iritis or uveitis. Bursitis, I talked about the bursae that are on your hips, it's on your elbows. These are little small fluid filled sacs and they cushion your joints. These can be damaged from repetitive motions or positions that irritate the bursae. So I talked about laying on your living room floor on your side because those bursae are in those hips. And even though you might be laying on the carpet or even a small pad, underneath that is concrete. And that can draw to those bursae or irritate them. Other things that might irritate would be things like throwing a baseball, washing the floors on your hands and knees. So you don't have to do anything aggressive there. It's just the pressure on there against, certain, especially concrete. If there's concrete under those floors, and most floors, even in a house, have concrete under them because that's the base for the floor usually. So if they did have bursitis, we would see things like swollen, red, achy, or stiff areas, or pain, or tenderness when you try to move. Usually, you would need like an MRI or something like that to actually see it. And then synovitis, this is when the synovial membrane is inflamed and it causes restriction in the ability to move your joints. It causes swelling of the synovial sac. The joint itself can become swollen, red, and warm. And we can actually analyze the synovial fluid to look for either signs of infection or sometimes in those joints, even in the knee, that gout can get in there if it's severe. And we might be able to see gout crystals there. We might be able to see them in the toe. Toe is where you're mostly going to see it. Tendonitis, this is when we have inflammation or irritation of the tendons. They'll have dull, aching pain at the site of the tendon attachment, could have mild swelling. It could be caused by some sort of trauma, but most of the time, this is again repetitive action. So, like a tennis player, um, quarterback throwing the football. Okay, so think about people that do repetitive things, swinging that golf club. All right, that's it for musculoskeletal. Okay, now we're going to do chapter 15. Let's see. Okay, so this is going to be eyes and ears. And first thing we're talking about is receptors in the body. Okay, so for the eyes and the ears, these are considered sensory organs. So you have special receptors there. Your exteroreceptors, these are close to the body surface, the cutaneous receptors, and they respond to things like touch, pressure, temperature, or pain. You have your visceroreceptors. These are located internally around the viscera. And then your proprioceptors, and these are your muscle sense. So exteroreceptors, These are close to the body surface. They're referred to as cutaneous. Again, they respond to things like touch, pressure, temperature, and pain. And then visceroreceptors, these are internally, these are around your viscera or your organs. And then proprioceptors, I would really remember this one. These provide information about your body movement, orientation, muscle stretch. Your proprioceptors are also referred to as muscle sense. Then you have mechanoreceptors. These are stimulated by mechanical force, touch, pressure, equilibrium, and hearing. So they're classified by their stimuli. Your chemoreceptors, these are activated by change in a chemical concentration like taste or smell. And thermoreceptors, these are stimulated by change in temperature, warm and cold receptors. You have photoreceptors. These respond to light. And then nociceptors, which we talked about in chapter 4. Remember, those are responding to tissue damage or pain. Osmoreceptors, which we talked about when we did fluid and electrolytes and a couple other things. And those are in the hypothalamus, and they recognize changes in your osmotic pressure. So remember, when you become too salty or when you're not salty enough. Visual information is received in your brain from light rays passing through the transparent cornea and the lens. That image will then focus on the receptor cells in the retina where the rods and the cones are. That stimuli, that visual stimuli, is then conducted by the optic nerves to the occipital part of your brain, where your brain interprets it and processes it, and then it sends it to other areas of the brain so that it can take an action or do what it wants to do. The eye itself is protected by that bony orbit in the skull. You have eyelids, eyelashes. These help detect anything foreign and help keep it away from the eye. They also protect the eye from too much sunlight to keep it from drying out. You have the levator palpebrae. This is the muscle in the upper eye, and that's controlled by cranial nerve 3, the oculomotor nerve. Your eyelids are also lined with mucous membranes, and it's known as the conjunctivae. That provides the sclera over the eye and helps protect the eye. I'm sorry, goes over the sclera and helps protect the eye. The sclera is separate. Continual secretion of tears help wash away any particles, any bacteria, anything that's irritating. And in those secretions are enzymes, lysosomes that help protect the eyes against any sort of bacteria. Tears can form in the lacrimal gland on the superior lateral part of the orbit, and then they flow across the eye into that medial corner, into the nasal cavity through the nasal lacrimal duct, and the tears keep the eyes moist and healthy. Sometimes with babies, that lacrimal duct can get clogged up. And so you may have had to massage your own babies or someone else's lacrimal ducts to try to get those tears to flow. Give me 1 second, guys. Okay, you guys can see it again and hear me?
Yes.
Okay. All right. So also in that eye is the ocular muscles, and those are going to control the movement of the eyes. There's six of them. You guys might have done an eye exam on someone where you talked about the cardinal fields of gaze, and it's these six extraocular muscles that are controlling that test that you're doing. And what you're looking at is to make sure that the eyes can go like six different directions, like oblique, side to side, up and down. So you might have done that or learned that when you were in PN school, if you remember it. There are four straight rectus muscles and two oblique muscles, and these coordinate and move the eye and rotate the eye, and they're under control of cranial nerves 3, 4, and 6. The eye is spherical shaped. It's filled with fluid. The main parts are the cornea, the iris, the pupil, the aqueous humor, the lens, the vitreous humor, the retina, and the optic nerve. Now, the iris is going to control the size of the pupil. So it allows light to enter the lens based on dilation and constriction. So that allows light either to enter or prohibits it from entering. The light enters the eye by passing through the cornea and the aqueous humor. Then the lens focuses the light through the vitreous humor to reach that retina. In the retina, there are specialized cells called rods and cones, and these can convert light into electrical signals. And those electrical signals are then sent to the optic nerve to the brain. The anterior part of the eye is a tough, fibrous coat, and this is where the sclera is. Um, I'm sorry. The anterior portion of the three layers differs from the posterior portion because it allows light to go through. So the outer layer or the posterior portion is the sclera, and the anterior portion is the cornea. You really don't have to know all that, but you do have to know. I mean, you should know the basic structure of the eye, and you might not remember that offhand if you're not looking at eyes all the time. But you just want to know that you have that outer coat where your sclera is, that inner part where the cornea is. The light is going through the lens and the cornea. That's the transparent part of the eye, and that has to be transparent in order for the light signal to go through. But at the back part of the eye, it's not going to be transparent. It's going to be fibrous. So that's really all that that's saying there. The sclera is the white part of the eye, and the cornea is the transparent part where the light rays are passed through and refracted. So if you look at somebody's eye from the side, you can see the curve in their cornea. The cornea itself, and you have to know this, okay? The cornea itself has no blood vessels. It gets nourishment from the fluids that are around it, and it gets oxygen from the atmosphere. So if someone wears contact lenses all the time, it can prevent that oxygen from entering the eye. This is why contact lenses have to come out, amongst other reasons. Okay, but this is one of the main reasons, is because it can affect the ability of the eye to get oxygen. The middle layer is called the uvea. So remember I said when you have uveitis, that's that middle layer that's infected or inflamed. The uvea is made up of the choroid, and so it's darker. It's adjacent to the sclera. The dark color helps absorb light and prevents the light from reflecting inside that orbit. There are blood vessels in the choroid, and these supply the retina. If that choroid gets pulled away from that retina, like in a retinal detachment, then that retina is not getting any nutrients. In the anterior part of the eye, the choroid will develop into the ciliary body and the iris. The ciliary body has a ciliary muscle. It controls the shape of the lens to help focus on near and distant objects. For older people, that part becomes a little bit broken because their lens doesn't have the ability to adjust as much anymore. So they develop what we call presbycuspis, which is farsightedness, okay? And it's caused by that lens not being able to change shape or adjust to the distances anymore. So if you notice when they're at the table and they're trying to read the paper, what do they do with that newspaper?
They pull it further away.
Right. And sometimes they might even ask the waitress, hey, could you hold this paper over there so I can read it?
Yeah.
So it's farsightedness based on aging. Okay. And that would probably be a test question. I would expect to see that. And
And
we'll talk about it more when we get to that part. I'm
I was
sorry.
told by my optometrist that it happens like once you pass the age of 40 because they checked me for that and they told me I may need bifocal soon.
Okay.
Um
So it
yeah.
can happen to anybody. It can happen at different ages. And there are certain things that can make you more at risk for it, like smoking. Are you a smoker? Have you ever been?
Yes.
Okay. So, smoking can predispose you to a lot of things with your eyes, cataract, all types of stuff. So, other things that could affect this also might be like genetics, things along that line. All right, so it's affecting the ability of the lens here to focus, and that's really the major issue there. So your ciliary muscles are controlling the shape of that lens and helping that lens focus. So when you're near something, you can see it. When you're far away, you can see it. People that have nearsightedness or farsightedness, they have a problem because of some other things. It's not this muscle necessarily that causes it. And we'll talk about that when we get to it. But they do have a problem when they have to change from near to close because of whatever their issue is. So if you're nearsighted, you have to be close to objects to see them. And if you're farsighted, you need to be far away. Also, the ciliary processes, they help secrete aqueous humor. That's the fluid in the anterior part of the eye. The iris surrounds the pupil, and that's where the light rays pass into the interior part of the eye. The iris is pigmented and gives the eye its color. So if you have brown eyes, blue eyes, your iris gives it that color. The iris also has two muscles that control the size of the pupil, the circular or the sphincter muscle, which contracts in response to either parasympathetic stimuli or excessive light on the retina, and that can cause the pupil to constrict. Under sympathetic nervous system control, the radial muscles of the iris, when contracted, cause the pupil to dilate. So if you remember in fight or flight, your eyes are dilated, okay, to allow your improved vision, especially in dim light. That's what's happening. Okay. It's allowing more light. It's allowing you to see better in that fight or flight. In parasympathetic, it'll be more constricted, so less light coming in.
Miss Losh, your slide is not changing.
I know I'm not there yet, but I'll change it now. Okay. Go ahead. There you go. You guys have these slides anyway, right?
Yes.
Okay. All right. So that was the middle layer, okay? The lens of the eye is transparent and it has a capsule around it. Nutrients are provided from the aqueous humor. Again, you have to know that. So remember, vitreous humor and the choroid, that is helping with the retina. Your aqueous humor is providing uh, nutrients to the lens. Together with the cornea, the lens provides refractive power for the light entering the eye. The lens is held in place by ligaments. The shape of the lens is altered as contraction of the ciliary muscle alters tension on those suspensory ligaments. So, what do you have to remember there? What I just said basically is that the ciliary muscle is help controlling the shape of that lens and helping it adjust to either close up or far away. Okay, that's the main thing you have to remember there. But this is all part of the A&P, so it's built into here. The lens can change its thickness and its curvature, and that is what allows it to focus on objects from varying distances. The adjustment in the lens curvature or accommodation helps bend the light rays that enter the eye to focus the image on the retina. If the lens has an irregular curvature, then you're going to be more prone to astigmatism. Cataracts are another lens related visual disorder where the lens becomes opaque or hazy. Okay, inner layer. The inner layer has the retina. The multi-layered coat is present only in the posterior 2/3 of the eye because the light rays are passing through the lens and they cannot bend enough to reach the retina. The retina has a pigmented layer, several layers of neurons. In the center of the posterior retina is the macula lutea. And there you have the fovea centralis. This is where your best vision is, your most acute vision in that fovea centralis. And when we talk about macular degeneration, this is the part of the eye that's going to be damaged. All right, your visual acuity is sharpest at the fovea centralis. The innermost layer of the retina has rods and cones that are light sensitive receptor nerve cells. The rods are specialized for dim light or night vision, and the cones are specialized for color. Light energy is absorbed by these rods and cones, and then it's converted into electrical energy. Because remember, once the eye gets the signal, then it has to convert it and send it to the brain. Some people have color blindness. This is usually going to be in men. Okay. And that's because, again, it's on the X chromosome. Remember when I was talking about X chromosomes, men only have one. All right. So whenever that X chromosome is affected, it's considered sex linked color blindness, by the way. So mom will carry it, give it to the men or give it to the boy. Okay. And they're more likely to have it than girls because they only have one X chromosome. So how these cones work is if an object has a color other than the primary color, then the red, green, and blue cones will activate to produce that color. If it's a primary color like red, green, or blue, then the red cone would activate in red light, the blue cone would activate in blue light, the green cone would activate in green light. But let's say the color was white, then these colored cones would mix together to produce that color of white. All right, the retina has a pigmented layer with several layers of neurons. Again, in that layer is going to be the macula lutea, that fovea centralis, and that is your acute or your central vision. As far as the rods and the cones, I would really just remember mostly that the rods are for dim vision and the cones are for color. The posterior cavity has the lens and the retina. It also has the jelly-like vitreous humor. The vitreous humor holds the retina against the choroid, and that helps the choroid provide the nutrients to the retina to maintain the shape and the size of the eye. Sometimes people can have little specks floating through here, known as floaters. The anterior cavity is between the cornea and the lens. It divides the anterior chamber. The posterior chamber is between the iris and the lens, and the chambers are connected through the pupil. The anterior cavity is filled with aqueous humor. It's secreted by those ciliary processes into the posterior chamber. The canal of Schlemm is also there, and that encircles the eye at the junction of the cornea and the iris, and it brings the fluid to the blood. So whatever fluid is in that eye, that's supposed to be draining out of it, putting back into circulation. Okay. And that's how maintaining the ocular pressure in the eye. If that canal of Schlemm becomes blocked, then likely your client has some sort of glaucoma. To maintain the intraocular pressure in the eye, we would like to keep the range between 12 and 20, with the average being 15. The aqueous humor that's formed has to equal the amount of fluid reabsorbed. We have to keep it below 24, and it's typically higher in the morning. Normal pressure maintains the shape of the eye. The aqueous humor supplies nutrients to the lens and the cornea, which do not have blood vessels. So again, this is what you have to remember. The aqueous humor supplies nutrients to the lens and the cornea. There's no blood vessels there. The vitreous humor holds the choroid against the retina to help supply nutrients to the retina. We good with that? The light rays are moving through the cornea where they're refracted through the aqueous humor and the pupil. The lens curvature will help adjust to refract the light rays so that they converge on the retina, and that provides that sharp image of the object that you're seeing. The light continues through the transparent aqueous humor to the retina, where the photoreceptors, the neurons, the rods, and the cones are stimulated. The light energy is then converted into an electrical stimulus, where it's transmitted by the optic nerve to the occipital lobe in the brain. This is where the image is identified, integrated with other information. The double image projected from different angles by the two eyes provides a wider visual field. The fields actually can overlap, and that gives you that depth perception. There are impulses being sent from the ganglion cells in the retina. This is all being controlled and works in conjunction with the optic nerve, cranial nerve 3. These impulses then leave the eye at the optic disc in that posterior portion of the eye. The central retinal artery and veins supply the retina. These vessels and structures pass through the optic disc. There are no rods or cones at the optic disc. So there's a blind spot there. Because the optic nerve is a projection of brain tissue surrounded by cerebral spinal fluid and meninges, assessment of the eye can sometimes provide us useful information about other problems in the body, like hypertension, vascular changes because of diabetes. The optic nerves carry the visual stimuli to the occipital lobe in the brain. The optic nerves from each eye unite at the optic chiasm. At the optic chiasm, now somebody was asking me about this in chapter 14, okay? So here's your answer about what's happening there right here. This is where you have to know it. At the optic chiasm, half of the fibers from each optic nerve cross to pass to the occipital lobe in the opposite side of the brain. The left occipital lobe gets the information from the right visual field. Damage to the left occipital lobe results in loss of vision in the right visual field. The parts of your eyes work together like a relay team. They pass the light that enters your eye along a pathway to the brain. The light passes through the cornea. That's the clear part at the front of the eye. The cornea focuses the light through your lens into the retina. That's at the very back of the eye. The retina then converts that light into an electrical signal. Your optic nerve will then send that electrical signal to your brain, and your brain will create the image. Charts. That's your visual pathway. Sorry. That's what I was just talking about. Okay. Any questions on that? You can see where it crosses over there. It shows you on the left side and how it crosses over and goes to the opposite side of the brain. It also shows you about damage, okay? If you had damage to the optic chiasm, you would be totally blind. If you had damage to the right occipital lobe or right optical tract, you'd have loss in the left visual field. If you have damage to the right eye or the optic nerve, then you would have blindness in the right eye. So why does it change when you get down to 3? Because where the damage is occurring is between where that optic chiasm is. All right, Snellen charts. The Snellen chart are lines and numbers, and they use these to look at vision. Okay, so I would know that the Snellen chart measures your visual acuity. Other visual checks that we do, visual field test. This looks for central and peripheral vision. Why is that important? If you have damage to the macula, okay, in that fovea centralis, what kind of vision are you going to lose?
Central.
Central. Okay, so you'll be able to see out to the side, but like if you're trying to thread a needle, if you're trying to do something that requires focus, you won't be able to see it. It'll look blurry. What about peripheral vision? So we can lose that with something like glaucoma. And so with glaucoma, when they look, it looks like they're looking in a tunnel. They can't see out to the sides. Why is that a problem? You
Because
can
you need
still see what. Go ahead.
because you made a drive.
Okay. Well, you'd be able to drive, but you'd have to be very conscientious about doing what?
Mm.
Moving to the
Looking
side.
side to side.
Mhm.
Yes, looking side to side, like turning your head. Now, a lot of times when you walk up, let's say you're in New York City and you're, walking down the street, you're crossing the street, okay? You come up to the crosswalk. You don't necessarily always have to turn your head to the side because a lot of times you can see what's happening without turning your head, right? These people can't. They have no idea what's on the side of them because they can only see in this tunnel vision. Tonometry is checking that intraocular pressure. So I was talking about the canal of Schlemm. There's also something there called trabecular meshwork. And so when someone has glaucoma, both of those things can affect their ability to maintain the proper pressure in the eyes. So we'll usually give them something to bring that pressure down. Usually Timolol or some other products, okay? And we're trying to decrease that pressure in the eye because it's too high. That's what happens in glaucoma. Either that canal of Schlemm or that trabecular meshwork is stopping that eye from being able to properly drain, but it's still getting new blood and fluid pumped into it, but it can't drain out. And so that increases or can't drain out properly. That increases that pressure. We also have ophthalmoscope. This looks at the interior part of the eye. And actually, like when you're talking about things like papilla edema, okay, or swelling of that optic disc, a lot of times you'll be able to see it with that ophthalmoscope. And then gonoscopy, this measures the angle of the anterior chamber, which might be important again in someone that has acute narrow glaucoma because the angle changes between the lens and the cornea there, and that's what causes the damage there for that eye. That's a more medical emergency, that acute narrow angle glaucoma. The chronic glaucoma is not a big deal, but acute narrow angle, that's going to be an emergency. And then muscle function and coordination tests. So we were talking about that when we were talking about those 6 ocular muscles, and I was talking about the cardinal fields of gaze. And you'll look at these muscles, the oblique, the one that goes side to side, all those to see if the eyes are functioning and moving in a direction, a coordinated direction, the way they're supposed to. So each row of the Snellen chart is a level of visual acuity based on 2 numbers. So the first number, which is usually 20, represents the client being 20 feet from the chart. The second number is how well that person can read from 20 feet. So, for example, if someone has 20/20 vision or normal vision, they can read a line from 20 feet away that any other average person could read from 20 feet away. If someone has 20/50 vision, it means they have to be 20 feet away to read a line from the chart that someone with normal vision could read from 50 feet away. This helps us prescribe corrective lenses and restore vision. Myopia is nearsightedness. This means you can see objects close, but not far away. So if you're nearsighted, you might not be able to see a highway sign until you're right up on it. These people need to sit at the front of the class. Hyperopia is farsightedness. You can see things better far away, but when your eyes are up close, they become blurry, and it can actually lead to discomfort like headaches, especially if you're reading, writing, doing computer work. These students need to be at the back of the class. I'm sorry, I said presbycuspis, and that is hearing, okay? Presbyopia. Pardon my broca there this morning. All right, presbyopia is farsightedness associated with aging. So you have a loss of elasticity in that lens and it's not able to adjust. That's what accommodation is. When you have accommodation, you ever see somebody do an accommodation test? Have you ever done one? Have you ever done Perla?
Yes.
Yes, Perla.
Okay. So the last part of Perla is accommodation. So how do you do it? How do you perform that test? Come on, you've done it. How did you do it?
Isn't that when you bring an object close to them and pull it back?
Okay. And what's supposed to happen?
The eyes will go inward, and then like as you pull back, it'll start to like separate, go
So
back
the
to
lens
normal.
should actually be adjusting on the object. Like they should be able to, when you bring it in closer, still be able to focus in on that object. When the eyes lose accommodation, they don't have that ability anymore to change from close to far away. So remember, we're talking about the newspaper here. And we're bringing the newspaper typically close to the eyes when we're reading, right? Really, when you read a book, I mean, you usually have it within about 6 or 8 inches of your eyes, right? Here, if you put the book that close, what's going to happen? Or the newspaper.
You're not gonna be able to read it
Why?
because you have farsightedness.
But what's it going to look like?
Blurry?
Yeah, it's going to be blurry. So normally I should be able to hold the newspaper out a certain distance and you should be able to see it and read it, at least the bigger print, right? And then when I bring it in towards your eyes should be able to adjust and still read it. In older adults, they lose that ability of the lens to adjust there. And so now, because your lens can't adjust, you need a lens that can adjust for you. So what do you end up with? Cheaters or bifocals, right? Or you can have LASIKs, right? You can have LASIK surgery, but insurance company doesn't pay for that. That's considered cosmetic surgery. So if you wanted to have like when I had my cataracts done, one of the things they offered me was to have the bifocal lens put in my eye. Because you can do that now. You got to pay like, I don't know. It was like $1,500 or something to do both eyes. Maybe more than that. I was
Need
just
that.
kind of wondering about it because I know, like with my bifocals that I have now, or with the cheaters that I use now, I didn't ask about it because I'm like, I'm not doing that. But if I was going to do it, I was just kind of curious and wondering, like, okay, like when I use cheaters now or bifocals now, like the strength doesn't stay the same all the time. Like the strength I needed 5 years ago is a different strength than I need now. So, what would happen if I had them implanted in my eyes? How would that affect them? It was just food for thought that I was thinking about that I would want to know before I would actually even consider that. But I didn't do it because I didn't want to pay $1,500 out of pocket for that. And actually, once I got the cataracts fixed, the eyesight is much better. I don't need the as strong as of bifocals. They're pretty minimal, the strength on my bifocals or on my reading glasses, my cheaters now. So actually getting the cataracts fixed helped that a lot. Why do you think that happened? Because what are cataracts?
It makes the eye blurry.
Yeah, it makes it, well, it's
Cloudy.
haziness. There's haziness there. It's cloudiness over the lens, right? So when you
Mhm.
try to look through that cloudiness, yeah, it blurs things. It puts rings like halos and stuff around things, especially if we don't have a lot of light there. All right, myopia. This happens when the image is focused on the front of the lens or the eyeball is too short. So if the eyeball is too long, the light that enters the eye won't focus correctly. The images will focus in front of the retina instead of on the retina, and that causes blurred vision. So that's what's happening in myopia. When you're farsighted, the light rays don't focus either the way they should. If your eye is too short or the power of the focus is too weak, the image goes behind the retina, and that makes things look blurry. Other defects that we can have. This is your presbyopia, okay? So with normal vision, the image is focused on the retina. If you have presbyopia, because your lens doesn't flex, it doesn't adjust to the light properly. You see there, it's talking about it. All right, it gives you that farsightedness, but it's caused by age and that inflexible lens. Astigmatism comes from irregular curvature in the cornea or the lens. Strabismus is when we squint or we're cross-eyed, and that can cause double vision. It can be caused by a weak or hypertonic muscle, a short muscle, or a neurological defect. Strabismus is considered misalignment of the eye. Typically, one eye goes in a different direction than the other. Remember, those 6 muscles work together to control the movement and to keep the eyes going in the same direction. If you have strabismus, the muscles there will have a problem controlling that eye movement, and they won't be able to maintain the normal eye position. Strabismus in kids has to be treated immediately to prevent the development of amblyopia. Now, what is amblyopia? That's a lazy eye. This develops when strabismus and the brain continually suppress the image from that deviated eye. As a result, the eye doesn't get the stimulation it needs and it doesn't develop normally. And we call it a lazy eye. So we'll patch the strong eye, or we'll put atropine drops in the strong eye to make the weak eye work. Nystagmus is involuntary abnormal movement of one or both eyes, and it could be a jerky back and forth movement or circular motion. It can come from neurological issues. Sometimes we'll see clients having seizures doing this. It can come from cerebellar or inner ear disturbances, from drug toxicity as well. Diplopia is double vision. We also have ptosis. This is paralysis of the upper eyelid. This can be from trauma to the cranial nerves or paralysis of the extraocular muscles from damage to those nerves. This can happen in a stroke. With double vision, they lose depth perception. When both eyes focus on the same object, each eye sees it from a slightly different angle. The brain will then compare and process each eye's information to form one unified image. Depth perception is the ability to see things in 3 dimensions, including length, height, width, and distance. Depth perception is your brain's ability to discern the different distances between objects as closer or further. So you're able to see and tell what objects are closer or further when you have depth perception. It helps you judge distances when you're driving, playing, or even reading. Depth perception requires the eye's ability to aim and coordinate together. The images on the screen there illustrate how the same scene might look different in the left and the right eye. The objects are different distances from one another in the two pictures. The difference in the lateral positions of the object on the left and right image defines the retinal disparity for that object. The disparity in this scene is particularly easy to see in the arrangement of the champagne glasses and the hand that points on the right side of each scene. So you can see how your eyes can see two different images there, but your body will bring it back together. Symptoms of depth perception problems would be clumsiness or bumping into things, poor spatial awareness, avoiding certain activities, having difficulty catching a ball or judging the lines or out of bounds, bumping into people when you're playing sports, difficulty driving, reduced reading performance, poor handwriting. All right, so these are just pictures of different things here. So you can have a sty infection. That involves a hair follicle on the eyelid. So that's going to be up there on the far left there. This is usually caused by staph. You'll have a purulent exudate and a little bit of a mass there. Other infections you can get: pink eye, conjunctivitis, trachoma, or keratitis. And we're going to talk about those and what they are. So conjunctivitis, this is a superficial inflammation or infection on the membrane lining, the surface of the eye or the eyelids. Acute conjunctivitis is bacterial typically. It's referred to as pink eye. It's very contagious. It could also be fungal or viral. Trachoma is a bacterial infection. Okay, this comes from chlamydia, and it is considered a sexually transmitted disease. And it usually comes with contact from discharge from a person's eyes or nose that are infected. Adenovirus is the leading cause of conjunctivitis in adults with pharyngitis, fever, inflamed preocular lymph nodes. It's contagious. Herpes simplex can also be the cause of viral conjunctivitis. So, like, they touch a lesion and touch their eye. Conjunctivitis can also be caused by allergens like chemicals, irritants, chemical splashes, foreign objects. And what we'll see is redness, itching, tearing. If it's pink eye, we're going to have probably staph aureus present. The pink eye often happens in kids. The sclera of the eyelid are going to be red with the purulent discharge. This is for bacterial. And it's spread by the fingers, contaminated objects, contact lenses, makeup. Can cause this. And they usually use antibiotics because we don't want to damage the eye or the cornea. Chlamydia, trachomatis, and gonorrhea can infect the eyes of newborns if mom has an infection during delivery. Neisseria gonorrhea is frequently transferred to the eyes through self-inoculation, causing conjunctivitis, redness, and a heavy discharge would typically be seen here. They can also get infections from those contact lenses. So just some of the bacteria that can actually cause infections in that eye from contact lenses. All right, this one I would know, trachoma, caused by chlamydia trachomatis. They're going to get like what we call scratchy eyes. So they'll get like these little bumps on the inside of the eye. It causes follicles to develop there. It's highly contagious. It usually happens in like third world countries where there's not enough water to wash the face. The flies actually carry it to the eyes. If we don't treat it, the eyelids will become scarred. Lashes can turn inward, and that causes abrasions to the cornea. Globally, trachoma is the most common cause of visual loss, and it's easily prevented. So these clients will have scratchy eyes, no exudate. If you flip the eyelid up, you'll see these pearl-like follicles underneath there. Keratitis, I would know this one too. This is inflammation of the cornea. Usually severe pain here. Common causes are herpes simplex and trauma to the eye. Again, it's severely painful because the cornea has a lot of pain receptors. It can also be caused by HSV, but herpes simplex is one of the main causes. Trauma to the cornea also can cause loss here. Abrasions can develop from foreign bodies being caught under the eyelid, scratching the cornea. Cataracts is next. With cataracts, we have a cloudy lens. It's kind of like putting grease over the lens of a camera. So imagine if you had grease over the lens of your camera on your phone. What would your pictures look like? Age is the major factor here. Glaucoma, that is from intraocular pressure being increased. They lose that peripheral vision. Age-related macular degeneration, we're going to talk about these a little bit more. Here you have changes in the macula, and that results in a decrease in the sharpness of your central vision. And then retinal detachment, which is a medical emergency. The retina is pulled away from the layer of the eyeball, and that causes ischemia to the neurons of the retina. So glaucoma, here we have increased ocular pressure caused by excessive accumulation of the aqueous humor. It's the most common and preventable loss of vision. It can be acute or chronic, and symptoms would be halos around the lights at night, loss of peripheral vision, pain from intraocular pressure, and in the acute form, that pain's going to come on suddenly. Narrow angle glaucoma occurs when the angle between the cornea and the iris in the anterior chamber is decreased. With aging, the lens will enlarge and push the iris to the side and forward, and that blocks the outflow of the aqueous humor. The pupil's dilated, the iris becomes thick, and it fills up that narrow angle. That causes pressure in the eye to increase. The pupil dilates, blocks the drainage of the fluid there, and we'll have an increase in the intraocular pressure, rapid, severe face pain. and a decrease in their visual acuity. With chronic glaucoma, this is sometimes called wide angle or open angle. It's a degenerative disorder in older adults. Here, the trabecular network and the canal of Schlemm become obstructed. The outflow of aqueous humor gradually diminishes. The intraocular pressure will increase slowly and asymptomatically, so no pain here. That increased pressure causes damage, ischemia. If the pressure increases, it can cause damage to the optic nerve and irreversible blindness. So we treat it with eye drops routinely. For this one, a key thing that you might see on the test is the cupping of the optic nerve. So when you look through the pupil at the optic disc, it looks cupped or eroded because the optic nerve fibers are compressed. So this is just showing you a picture of how that aqueous humor should be flowing. Again, if that canal of Schlemm or that trabecular meshwork here is blocked, it's not going to be able to flow properly. And that's going to build up pressure in the eye. Chronic open angle glaucoma is slow. That's going to be a slow process, okay? So you have degeneration or obstruction of that trabecular meshwork or that canal of Schlemm. Again, they can open up the canal of Schlemm. They can try to put an opening there to help it drain. Sometimes they'll replace the trabecular meshwork. It really depends on what is the issue there. With acute, narrow, or closed angle there, okay, again, you see the narrowing of the cornea and the iris there. There's a narrowing, and so that narrowing causes the canal of Schlemm to be blocked, and that aqueous humor can't drain. With cataracts, the clear lens is becoming cloudy. It interferes with night transmission. Changes can be caused by degeneration to aging, metabolic abnormalities like diabetes, excessive exposure to sunlight, congenital cataracts. This is usually something that they're born with, so that can be caused by an infection in mom. Traumatic cataracts because they had some sort of damage or injury to the eye. So again, the lens is becoming cloudy. It interferes with the light transmission. The size, the density of the opacity can vary among people. Usually we don't fix this until it starts to bother them. Everyday living, they start to complain, and then the doctor's going to fix it. They'll have blurred vision that progresses over the visual field. It'll become darker with time. When the interference is severe enough that it affects the person's ability to function or work, we can remove the damaged lens and replace it with an artificial lens. They do that through a process called phacoemulsification. They use a laser. Retinal detachment. This is an acute emergency. The retina tears away from the choroid. Remember, the choroid is being held there by the vitreous humor to provide nutrients. This can happen because of marked myopia, degeneration with aging, or scar tissue that puts tension on the retina. So we need to bring these back together. Okay, if the retinal stays away from it, It's not going to get any nutrients and they could lose vision. Usually the sign of this is going to be like a curtain falling over the eye. It's sudden, painless, rapid loss of vision. So they describe it as a curtain or a veil being drawn across the eye. Cobwebs, flashes of light. The detached retina will allow the vitreous humor to flow behind the retina. That can increase the portion of the retina that's lifted away from the choroid. So it can cause additional damage and the retinal cells can stop functioning. The loss of function would result in an area of blackness in the visual field. As separation continues, the retina is deprived of its source of nutrients in the choroid and dies. Again, no pain here.
Hey, just 10:27. What the hell are you doing still asleep?
Mute, please.
Mm-hmm.
Mute, please.
Oh, sorry.
Age-related macular degeneration. This is a common cause of visual loss in the older adult. So again, macular degeneration is going to be in that fovea centralis, in that central vision area. Macular degeneration is a common cause of visual loss here. It comes from a combination of genetic and environmental exposure. Degeneration occurs at the fovea centralis in the macula lutea. Remember, that's where the most acute vision occurs. There are two types, dry and wet. In either type, the nutrients are not able to get from the choroid to the retina. So again, the retina is not getting nutrients. Central vision with high acuity first becomes blurred and then is lost. There's no treatment for this to reverse it. Depth perception also affected, but not your peripheral. There's two types. The more common is dry. Here we have deposits that form in the retinal cells and destroy them. In the wet form or the exudative form, neovascularization occurs. The blood vessels leak. And because of those leaky blood vessels, it destroys the retina. So that would be normal vision.
Yeah, my mom had the wet one. She had to go in for shots in her eye to stop the blood in the back of her
Uh-huh.
eye. Yeah.
So did the shots were to like what? Try to repair the vessel?
I think it was for the vessels to stop the vessel from leaking.
Okay.
Yeah.
So that's what you'll look like if you have it. Okay, so quite a difference there. All right, we're moving on to the ear. All right, so different parts of the ear. The external part is divided into three sections. I'm sorry, the ear itself is divided into three sections. I didn't even drink last night. Doggone it. What's going on with my brain? The ear is divided into three parts: the external ear, the middle ear, and the inner ear. So the external ear is the pinna, okay, and your external canal. The middle ear is tympanic membrane. That's where your little ossicles are, these small bony parts that are the smallest bones in the body. The ossicles, the stapes, the incus malleus. And then the auditory tube that connects to the upper respiratory tract. In the inner ear, you have the cochlea. That is your organ of corti or your hearing organ. And your semicircular canals, which are controlling your balance and your equilibrium. The external ear is the pinna. which is the visible flap on the side of the head, the external meatus or canal. The canal passes through the temporal bone to the tympanic membrane or the eardrum, and that marks the separation between the external and the middle ear. The middle ear is the tympanic cavity. It has those three tiny bones, the malleus, the incus, and the stapes, and they make up the ossicles. The malleus is adjacent to the tympanic membrane, and the stapes fits against the oval window and connects the middle ear and the inner ear. The inner ear is called the labyrinth. It's composed of two parts, the cochlea, the semicircular canals, joined by a vestibule. There are structures there made of the bony labyrinth that is a fluid filled membranous endolymph. Let me say that again. In that bony labyrinth, you have fluid, it's called perilymph fluid. Okay, and it's going to fill that area up with endolymph fluid. Why do you have to know that? Because that endolymph fluid, that perilymph fluid, is what causes sound to occur, and it's also what helps with your balance. So in someone that has Meniere's disease, have anybody ever heard of anybody with Meniere's? Have you heard of Meniere's? No one?
I have.
So in Meniere's, you have too much endolymph fluid. And so someone with Meniere's has difficulty not only with hearing because of tinnitus, but they also have a problem with balance, equilibrium. They'll experience severe vertigo. So you always have to worry about their safety. And you'll have to know about Meniere's disease. You also have the cochlea here. This is an arrangement of membranes surrounding the organ of Corti. That's your hearing organ. Here you have cranial nerve 8 conducting impulses to the temporal lobes for reception and interpretation of sound. There are fibers there that cross from each ear to the opposite side of the hemisphere. Some of them stay on the same side, and that means that your ears can get sounds from both the right and the left side of the brain. So the hearing starts with the sound waves in the air. The height of the wave determines the loudness of the sound, and the number of sound waves determines the pitch, whether it's high or low. Sound waves enter the external ear canal and hit against the tympanic membrane. That causes the tympanic membrane to vibrate. The vibration of the tympanic membrane causes the malleus to vibrate, and then the incus and the stapes. The motion of the stapes vibrating against that oval window causes the movement of that perilymph and that endolymph fluid in the cochlea. The water waves from that perilymph and endolymph fluid will stimulate the movement of the membranes and the hair cells in the organ of Corti. And then the organ of Corti converts that stimuli into a nerve impulse. And then that electrical nerve impulse is conducted to the auditory area in the temporal lobe of the brain where the sound is received and interpreted. The semicircular canals are three structures, and they're formed at right angles to each other to help you maintain balance and equilibrium. The crista ampullaris, located in the ampulla of each semicircular canal, and in the macula, and the vestibule is also located there. The receptor hair cells there can be stimulated by the endolymph fluid whenever you move your head or change position. So that's important because that's going to help you maintain balance. So your body's using these angles that these semicircular canals are positioned at. It's using those angles, your receptor hair cells, and that motion of that endolymph fluid in order so that when your body moves, you don't feel dizzy or off balance. It allows your head to pick up movement in any direction. Any stimulus conducted by the vestibular branch of the auditory nerve to the medulla oblongata, where the cranial nerves are, or other parts of the brain, so that the brain can interpret it. There are other connections to the cerebellum, like incoming proprioceptor impulses. Remember, I said those are your muscle sense. So you have incoming signals from those proprioceptor impulses regarding the joints, the muscles, and the tendons, and to visual stimuli. And all these together work to coordinate your reflexes, maintain your posture, and prevent you from experiencing vertigo or dizziness when you're moving. If there's damage to the vestibular area, it can lead to vertigo or a sense of rotation of yourself, or maybe you feel like you're spinning or the room itself is spinning. So with people with Meniere's disease, because they have excessive endolymph fluid there, some of the other parts of the ear can't work. Remember, if we have too much fluid, right, that can put extra pressure or cause problems. So when they have Meniere's, they have extreme vertigo, a feeling of everything spinning, moving. You have to know about this hearing loss. What type is what? Okay. So we have two types, conduction and sensory neuro. Conduction occurs when sound is blocked in the external or middle ear. You have to know what this is and what causes it. So this can be from wax, some foreign object, anything that might be stuck there that blocks the sound wave. Scar tissue. Sensory neuro impairment. This is mostly in the how the older adults, what they'll have is sensory neuro. Okay. But other people can have sensory neuro impairment also. This, we're having damage to the organ of corti, or that hearing organ, or the auditory nerve. This damage comes from infection, head trauma, neurological disorders, ototoxicity, infections. Loud sounds, prolonged exposure to loud noise causing damage to the hair cells. And then presbycusis, okay? So we have presbyopia, that's eyes. Presbycusis is hearing of the older adult. And again, sensory neuro loss is typically the cause of this because they don't have enough hair cells, or because the cochlea, which is that organ of hearing, is broken down or damaged. Newborns are screened for hearing deficits because they can be born with congenital deafness, and that can be inherited. It can be from an infection or trauma. So we need to know early if these kids have a hearing problem or not, especially if you're going to give them something like a myosin, like gentamicin or vancomycin. Okay, mycins never let you win. They're toxic to your kidneys and your hearing. So they are considered an ototoxic, nephrotoxic drug. So if you're going to give a baby gentamicin, you might want to check that hearing before you give it. Because if you give it and you damage the hearing, it's not going to come back likely. Other ototoxic drugs would be like furosemide, aspirin. Those all cause tinnitus. And tinnitus is like a ringing or a buzzing that you can have in the ear. So for babies, we want to try to get with them right away if there's something going on with the hearing, because it can affect their ability to develop speech as well. We can use things like sometimes hearing aids or cochlear implants to help these kids if we know. But usually we want to do interventions when they're young before they start to develop that speech. This is showing you the cochlear implant, okay? It provides a vibration there to produce that sense of sound. There's actually an actor on TV that has one of these. And usually you would want to put this in when someone's young before they start to develop speech. They don't work as good if you wait till the person's a little bit older. This you need to know. Otitis media, this is inflammation or infection in the middle ear. It can cause exudate, pressure on the tympanic membrane, and pain. So usually an indication that the eardrum is ruptured is when the pain is suddenly relieved. Exudate can build up here and interfere with the ability of the ossicles to work right. The auditory tube itself can be obstructed from inflammation, preventing drainage into the nasal pharynx area or of the nasal pharynx. It can cause enlarged adenoids. Prolonged infection can cause scar tissue and adhesions, which can lead to permanent conductive hearing loss. Chronic infections can lead to mastoiditis, where the mastoid or temporal bone is involved. Usually, when that happens, they end up on like a PICC line, and that's very painful. The mucosa of the middle cavity of the ear can become inflamed, and that can cause the infection to spread because of the continuous mucosa. So they can end up with an ear infection because the nasal and respiratory passages are infected. This happens a lot more in infants or young children because they have a shorter auditory canal and it's wider. And also, it forms more of a right angle, and that allows for the respiratory secretions to go into that auditory area. Sometimes the ear infection is asymptomatic, but most of the time we're going to have severe pain related to the pressure on the tympanic membrane and the nerve receptors. The tympanic membrane is supposed to be pearly gray. Here it's going to look red and bulging. For babies and young children, they'll rub or pull at the ear. They might feel full or congestion. They can also have fever, nausea. Again, if it ruptures, they'll have a sudden relief of pain. Otitis externa, I would know this. This is also called swimmer's ear. So a lot of times they get it from swimming, but they can get it from frequent use of earphones or earplugs as well. This is infection in the external auditory canal and the pinna. It's usually bacterial. So we have to clean those earplugs good. And also we could use something called swimmer's ear in their ears. Make sure the ears are well dried after they swim. If they continue to get the infection, then we might have to have them maybe use earplugs when they swim. So that's your normal tympanic membrane. And again, they describe that as like a pearly gray sort of look. And then otitis media is red and bulging. All right, there's your swimmer's ear. Again, usually bacterial from swimming or use of those earphones. They can have pain with it. Otosclerosis. This is where the stapes becomes fixed to the oval window and it doesn't vibrate. And that blocks the conduction of the sound because that vibration is needed, remember, to make that fluid move, that endolymph and that perilymph fluid. If that doesn't move, you're not going to conduct that wavelength. Otosclerosis appears to be genetic. Meniere's syndrome. This is an inner ear disorder. You have excessive endolymph fluid. It stretches the membranes. It interferes with the function of the hair cells in the cochlea and the vestibule. It can cause rupture of the labyrinth membrane. It can also cause vertigo, dizziness, loss of balance, falls. So safety is a huge thing for these clients. Tinnitus, which is that ringing or roaring like noise, unilateral hearing loss, nausea, sweating, inability to focus, nystagmusm, where you have that involuntary rapid movement of the eye, pressure in the ear, and over time, this is going to damage the hair cells permanently. They can permanently lose hearing and develop permanent vertigo. All right, so severe vertigo, tinnitus, unilateral hearing loss. Again, another one that you have to know. And then the last one is just diagnostic. So that's it.